We had a 40-bed inpatient facility, and we knew that people didn't always need that level of care. We knew that we could, without having them involuntarily detained and put into an inpatient facility, we could provide them the services on another level.
There was a motivation on several fronts to do this project. One is some of the counties have large mental health campuses, and on those campuses, their inpatient programs were often larger than what was allowed to be billed to Medi-Cal. We had a large 40-bed facility that cost us several $1 million a year, and for none of those inpatient services could we bill Medi-Cal. The billing of Medi-Cal is important to us because whenever we bill Medi-Cal, we only have to pay for 50 cents on the dollar, and the federal government gives us the other 50 cents. So we had a 40-bed facility that wasn't generating any revenue at all.
So we worked with a team, including therapists and nurses and administrators and psych techs and a variety of people and input from consumers too, to work to see what the best mix was going to be for us to work with them.
And so what we did then is we focused on a project that could generate some revenue, and we also were cognizant of what had been coming about primarily as the result of Prop 63, the Mental Health Services Act. With that infusion of additional resources, while it's still not nearly enough, it allows us to expand the outpatient continuum such that folks stay better maintained and stable in our system, and we remain connected and linked to them. When they drift off and become isolated, a lot of times that's when they begin to become ill. And if they stay connected with county mental health services or through our contractors, then there's a much better likelihood that they'll remain stable and healthy.
For a long time, people had to become very decompensated and come to the attention of authorities, whether it was law enforcement authorities or through the hospital emergency room before we saw them, which in almost all cases meant that they were going to be there for 72 hours or up to 10 days or so. What we realized was if we had what we call our crisis stabilization unit, CSU, a under 1 day unit, the people actually come to us when they knew they were doing bad. They'd say, okay, I need a tune-up virtually. I mean, they'd come to us and we'd be able to bring them in, get them some medications to stabilize them, and get them back to the community. And through the continuum we developed, we have crisis residential houses in the community where they could spend a week to 3 weeks. And while they're there, they would come back and see their psychiatrist daily if necessary to get their medication adjusted. So they were in the community, they were having programming, they were having therapies of a variety of sorts, and they were also getting their medications adjusted to avoid that 10 days involuntary hospitalization.
According to my caseworker, Paula, I've been in and out of crisis and inpatient hospital 70 times before this program. Since I've been in the program, I haven't gone back there once. They provide my needs where I don't have to be seen in crisis all the time or in and out of the hospital. If I have a problem, I'm able to call them anywhere from 8 to 5. Then after hours, they have the warm-up light that you can call if you have a problem.
Oh, Deena was very angry. She had a hard time processing her needs or making her needs known. She was a difficult client. Now that she's an outpatient, with our program and innovation, she's wonderful. She's a joy to work with. She has been. I'm so proud of her. When Deena came into the program, there was approximately 12 of us, and we all worked together as a team to try to help Deena attain her goals.
Since I've been there, I have really grown a lot, and I really changed. They have you set goals for yourself. You accomplish your goals there. You get to do different things with the program.
You meet your client where they are, and you see what they need, because each client is individual, and they all require different things. And then once you start there, you start the goal setting. Where do you want to see? Where do you see yourself in a year? What would you like to be doing? Once you get those in place, then we start groups or or we even take them to classes.
People want to take charge of their lives, and that's actually what we're trying to do with consumers and patients, helping them take better charge of their lives so that they can be, they can enjoy and should enjoy the liberties that they deserve.
The program has taught me how to have self-confidence, good self-esteem, good understanding with others, and good insight. I'm shooting for recovery and then maybe go back to school after the program. I've been considering it.
It worked. I mean, we started off with goal setting and we went through each client. We talked with them and we had them let us know what they wanted us, what they needed from us. So once we attained that, then we worked from there. Like Deena said, she needed sobriety and she needed wellness, and those are the groups we provided for her.
What we found is in a year's worth of service that of those who came into the crisis stabilization unit, most of whom would have gone to inpatient services, there were actually 38% of them had to go into hospitalization for maybe a few days, but 62% never had to be hospitalized in that time.
There is a cost, but Prop 63 begins to show you how well the investment is in developing a community mental health system. It's far less costly than placing people behind locked doors and in institutions once again.